Dr. Saeed Gamdi will have the session Dialysis Practice and Pattern in the GCC DOPPS study. It's all yours, Professor. Thank you.
بسم الله الرحمن الرحيم. السلام عليكم. كده كويس الصوت؟ بسم الله الحمد لله والصلاة والسلام على رسول الله. Thank you very much for the kind invitation, Isa and the colleagues. And thank you, Professor Saeed, for this introduction. And I'll just be actually a representative of my colleagues who are member of the DOPPS. And actually, if you look at DOPPS, DOPPS has been started first time in 1996 when they did actually several cycles, including cycle DOPPS 6, which is from 2016-18. And right now we are DOPPS 6, where actually this group of spread all over the world in many regions called DOPPS regions. And those regions, there is actually some representative centers from all these countries to represent the country as a whole. Unfortunately, GCC came to DOPPS almost 8 years ago or so, and we became part of the international arena of data of dialysis outcome and practice study, which is called DOPPS study. And from all these GCC countries, you could see that we have actually representation from various countries. And from Oman here, we have Isa Salmi and Nabil Muhsin, Yaqub al-Maymani. And we have actually from all centers here, and we have actually one al-Rakhaimi from Emirates, Bahrain, Ali Aradi, and from Kuwait, Sahwa and others. I'll show you some of the data of the DOPPS, just to tell you how we are faring compared to the rest of the world. If you look at the EGFR initiation, we heard from Dr. Turki Al-Ataibi about the study which showed that there is no difference between early or late initiation of dialysis. But if it looks, give you some other indication, like from GCC DOPPS, we look that we majority of our patients, they are starting late. Actually, more than around 95% of our patients, they start with GFR less than 10. This means that we are different from the rest of the world. We know that mortality, I'm not talking about mortality, morbidity, we talk about how we are late. We are late in the initiation of dialysis compared to the rest of the world, whether it's good or bad, or showing no difference. Okay, what about vascular access? Vascular access, interesting. Sorry, why you are? Okay. Oh, sorry. This is front or? Okay. Probably I'm missing, no. Yes, okay. Sorry for that here. I know how to skip this one. I think we just, can we go from the beginning, please? Again. So it tells you that, okay. Now just a slide before, please. Anyway, so if you look at from all the data, we are really starting late from dialysis. And I didn't show you here, actually, probably the catheter. Yes, here, I think we have something problem here. Can you go from the beginning, please? First slide, please. First slide, yes, go. Back. Again. Does it move? Again, more, please. Okay, more, come on, more. Okay, خلاص, it's okay. So if you look here, for example, that the majority of the patients actually they have catheter when they start dialysis, as it has been shown in this slide. So actually, very little patients, they are on access. If you go actually to majority of the patients, actually also, they don't have AVF compared to the rest of the world. And most of our dialysis patients actually in the GCC area, they are younger dialysis population compared to the rest of the world. And actually, we are similar to the rest of the world. We have majority of patients, they are male and less female. If you look at dialysis vintage, we are comparable to North America in terms that we have actually almost 3.2 years of dialysis when they did the study. And if you look at the body mass index, certainly it reflects that we are higher, similar to the North American populations. If you look at the treatment time, we are the worst in the world in terms of treatment time in dialysis, if you compare it to the rest of the world. And similarly, here we show the treatment time of GCC countries. Majority, they have actually almost more than 50%. They have low treatment time, around 180 minutes, maybe 3 hours plus for dialysis. Blood flow also, we are one of the worst in the world, just next to Japan. And we see that actually less blood flow, around 294 mils per minute. If you look at KT over V, that has reflected negatively in the KT over V. We are the lowest in KTAV in the world, 1.37, compared to the other regions of the world. And if you look at actually KTAV in DOPPS 6, similarly, we are less than the rest of the world. This is Isa Salmi looked at mistreatment and published in Kidney International, and showing that actually we are having high prevalence of mistreatment, and that might reflect also negatively on KT over V. This is a study by Ali Sahu, who is part of our DOPPS group. He looked at KT over V, which reflects the same thing which we discussed before. And most of our patients, as you see, as that area, that we have actually lowest KTV in the other region of the world, represented by other countries like Japan, Europe, and Canada, where we tends to have low. And the reason for that actually is due to many factors. One of them is the treatment time, and the other thing is the treatment time and low blood flow. And has been shown that this treatment time, low blood flow, is associated with the negative outcome with increased risk of mortality. If you look at the blood flow, which is really quite significantly reduced compared to the rest of the world. The access type, actually, we have, especially in Kuwait, we have very high temporary access and less arteriovenous fistula, which suggests that probably this is one other factor responsible for the low KT over V. So this actually from that regarding dialysis adequacy, we're lower than the rest of the world, probably due to high access, due to temporary access, high temporary access, low blood flow, low treatment time, and that's really reflects all on low KT over V. The second point about the mineral bone density is also Isa Salmi, who looked at mineral bone density in the Gulf regions in the first cycle of DOPPS. And it showed actually that we have the majority of our patients that are significantly having high PTH. Actually, only less than 50% of our patient population, they are within target of PTH. If you look at, for example, phosphorus, less than 50% of our dialysis population, they are having phosphorus within target, and the majority outside target. And if you're calcium, only 5% of our patients, they are having hypercalcemia. If you look at very strange here about some countries of DOPPS, country, especially DOPPS, where they have very high calcium bath in dialysate, specifically Oman and Bahrain. We have the majority of their dialysate about 3.5 milli equivalent to 1.75 millimole. And that's really high dialysate bath. Might be, okay, good to suppress PTH, but at the expense of hypercalcemia and other things, probably calcifications and a dynamic bone disease. It's not been investigated very well, but it's anticipated. But certainly they are different from the rest of the world. Although our region, they usually used to have high calcium bath. If you look at this again, Isa Salmi study about in kidney 360, looked at the parathyroid hormone mortality morbidity as a surrogate marker in relation to outcome. And here we look actually similarly that the PTH really is majority of our patients, they're having high PTH. And actually, in Saudi Arabia, they have the highest PTH from all GCC country in terms of numbers. And if you look at the best PTH you have, when you have 300 to 450, where they have the lowest mortality, and the highest mortality will be people having more than 700, and certainly people who are less than 150 also have increased risk of mortality. And this U-shaped curve, which has been constructed, showing the mortality is higher when your PTH is 300 and more than 450, becoming very high when you exceed 700. And that U-shaped curve has been shown in several studies, in international studies in the world, including DOPPS and other than DOPPS study, especially also for UCRDS data. So it shows that the U-shaped curve is really quite applicable and is better. That's why if you look at the KDIGO guidelines for regarding PTH from 2 to 7 or 2 to 9 of the upper limit of normal, or is equivalent around 300 to almost 600. This is the other study of Kozolino, same DOPPS group, and he took Saudi Arabia as one of the, as a representative of the Gulf states, all states. And look at the PTH by DOPPS country. If you look at Japan, Germany, Spain, USA, and other countries of the world, you look at the Saudi Arabia as a representative here, you find that they have actually the highest level of PTH from all the group. If you look at the phosphorus, we are not the worst, but it's not the best country. We could say even we are actually more than 50% of our patients at that time, at that DOPPS cycle, showing that we are really outside target. Dialysate calcium, as I explained earlier on, that Saudi Arabia, not different from the Gulf countries, they really tends to use high calcium bath, and actually here they use about 2.5, more than 2.5, the calcium bath. So Saudi Arabia is really, compared to the rest of the world, they have high calcium bath in their dialysate. This is actually regarding the anemia management. In summary, is not different from the rest of the world. We are doing very well in terms of anemia management on all parameters, except that we tend to have lower TSAT level when we start treatment. But the interesting thing here that some countries like Oman is the only one who's using the short acting only, and there is nothing compared to the rest of the Gulf countries. If you look at the nutrition, Fadwa Ali has led the group here and found just interesting that, which is really quite known, that when your hem or serum albumin less than 3.2, it tends to increase the risk of mortality by 2.46. So it's really quite significant. This study, which is about diabetes, and is really quite astonishing and actually alarming to some extent, that this study is showing, which is more recently published, showing that Gulf countries, they have some problem with diabetes. And we have some different characteristic from the rest of the other region, that we tend to have actually our diabetic population at younger age population, and we have actually much significant increased mortality, 15 point something per patient year, compared to 6 by something for non-diabetic population. So significantly increased mortality in diabetic dialysis population in the Gulf region compared to non-dialysis population, and tend to be heavier in weight, and also tend to be longer dialysis vintage, which may suggest that they don't survive that much on dialysis. So these actually factors, which really are shocking actually data to me, honestly, that we tend to have much more higher in mortality, and especially that regarding some other factor, which we'll discuss it later on. The most interesting in my judgment is look at the diabetes mellitus prevalence. I'm not talking about diabetes causing end-stage, but diabetes present in patients who are on dialysis in Gulf countries. And found that, for example, most of the countries, up to 70, 75%, 79% even, they have actually diabetes. And Oman and Saudi Arabia, they're the lowest in terms of diabetes. Saudi Arabia, about 45. And you could argue why Saudi Arabia 45, but I can tell you this data is equivalent to Scott data, equivalent to other data, which suggests probably it's the number 45% of the dialysis population of Saudi Arabia, they are diabetes. But if you look at Bahrain, Kuwait, and United Arab Emirates, Israel, Qatar is much higher than this one. The most interesting that poor care during dialysis, that the majority of the patients, they don't get hemoglobin A1C 4 months every 3 to 4 months. You find that the majority of the patients, they don't get tested, and especially in the only country which is really doing a very good job is Qatar and Kuwait, but the rest are really not doing frequent testing for hemoglobin A1C. Yes, 2 minutes. I'm almost done.
Okay.
Here, look at the risk of mortality is really, whatever measure you take in terms of certified, you find the risk of death is really higher in diabetic compared to non-diabetic population. And this curve showing the least mortality is between 6.5 and 7.5. If you exceed hemoglobin A1C that degree, you tend to have more mortality. If you drop your hemoglobin A1C further down, you find there is increased mortality. And this is the last study actually published by the DOPPS group, looks at pruritus as a marker, and they found in the study that the Gulf countries here, they're not different from the rest of the world in terms of pruritus. And more interestingly, that the higher severe pruritus, the worst outcome with increased mortality, as you could see it here in the curve. And also for hospitalization, much more hospitalization for somebody who's having severe pruritus, and all negative outcomes really associated with very severe pruritus, which is about 8% of the dialysis population. So in conclusion, GCC countries initiate dialysis at lower GFR with probably late presentation and the highest temporary access, and that's really clear. And GCC countries have the lowest KT over V, and probably due to the highest temporary access with low blood flow, lowest treatment time, and high missed treatment. The GCC countries had the highest PTH level, and 24% had very high PTH, like in Saudi Arabia, despite high calcium bath and equivalent phosphate binders, probably due to low use of IV vitamin D, and that really has been a fact which has been documented. Sometimes vitamin D, IV vitamin D is used less than 2%. And there is, more interestingly, there is a remarkable variability in dialysis prescriptions and treatment of anemia and others, CKD and BD in various countries of DOPPS region, especially in GCC. The high prevalence of diabetes in dialysis population in GCC country, highest than anywhere you could see it in the world, and higher mortality in diabetic hemodialysis patients in GCC compared to non-diabetic population, with the higher the hemoglobin A1C, more than 7.5, and less than 6 are associated with increased mortality and morbidity. Thank you very much for giving me your time. Thank you.
Thank you, Saeed. Thank you.